mouse underneath here.
Great. Good afternoon, everyone. I'm Dr. Kirsten Rowe. I'm a medic from South Africa who's currently busy with a DPhil in psychiatry here at Oxford, looking at the effect of HIV on the brain in adolescents and using music interventions to try and improve cognition and mental health in young people living with HIV. I wanted to just welcome everyone here and to just say that we're privileged and that the UN Deputy Secretary General, Amina Mohammed, will be joining us here in this session. I'm not sure if she's here yet. We also have a lovely panel of speakers from a wide range of backgrounds who will be, sharing their knowledge on the topic today and helping to facilitate a discussion. I'm going to try and make sure that we will have time for audience interaction and questions as well, so that it's not just a sort of a monologue up on stage, but that if you have questions about this, that you can put them to the panel as well. So I'll briefly just introduce each person on the panel, and then they'll tell us more about themselves before we delve into the topic further. So at that end, we have Dr. Ethel Nakimuli Mpungu from Uganda. She is a psychiatrist and psychiatric epidemiologist at Makerere University. Then we have Dr. Sibuyile Madikana from South Africa. He has not only a medical degree and an MBA, but is also now busy with his master's in public health at NYU. And then we have Father Valentine Erahon, who is based in London. He is a Catholic priest, but he's also got an interest in mental health and is currently doing a certificate program along those lines. So they'll each just briefly now tell us a bit more about their work and their interest in mental health before I ask them some more questions. So Ethel, starting.
Thank you so much, Christine. First, I'd like to say it's a great honor to be here to speak at Oxford University about the mental health work that I do in my country. I am a psychiatrist, as she said, and I worked in a psychiatric hospital for 10 years before I moved on to the university, where I work as a senior lecturer and a mental health researcher. I hold a master's degree in psychiatry and a doctoral degree in psychiatric epidemiology. And currently, I am leading one of the largest community trials on the continent of a group therapy program for depression among rural populations in northern Uganda.
Great, thank you. Dr. Sibuyile?
Hi, everyone. As said earlier on, I'm Dr. Sibuyile Madikana. I am a medical doctor from South Africa. I worked in the public health sector for a number of years and also in private. I hold an MBA with a specific research in digital communication and health behavioral change. And I'm doing currently a master's in public health, specifically in healthcare management and healthcare policy for the public healthcare sector. And currently I work as a researcher at United Nations Women.
Wonderful. Father Valentine?
Welcome, everyone. Father Valentine Erahon. A Roman Catholic priest. My background is in philosophy and theology, and also now mental health. And I work in a prison somewhere in London. That's my main job or ministry or vocation at this time. Every year since 2014, I supervise SSC program for student doctors from King's College in London. And we deal with end-of-life care, palliative care, and also for junior doctors on self-care. A course program really around the Kent area, Canterbury, Ashford, and Margate. So all around self-care, and I'm interested in that. And before you get to the problem, that's really my area. Before you get to the problem, what do you do before you actually get to mental health?
Okay. Thanks. Yeah, so I just briefly wanted to touch on the burden of mental illness in Africa. So according to the Global Burden of Disease study in 2010, mental illness and substance use disorders were the leading cause of years lived with disability. So they account for nearly 20% of the total burden of years lived with disability. In 2010, this was 20 million years or years lived with disability, and this is projected to increase to 45 million years lived with disability by 2050. So the burden is massive, but as the title said, it's this invisible epidemic, so often it's not even being spoken about. And we know that this conference is about moving from mere discussion to action, but you kind of need to raise it as a topic for discussion before it can even get to the action stage. So hopefully that's what we can be doing today. So I first just want to put it to the panel. What do you think some of the main challenges are in terms of raising awareness and kind of bringing mental health to the table as part of the public health agenda within the African context?
Yeah.
Would you like to start?
Yes, that's a very good question. The main challenge with mental health is actually understanding what mental health is. When the word mental health is mentioned, most people, they're thinking about the extreme violent behavior, that people see easily. But what I want us to understand in this forum is that mental health is not equal to mental illness or disorder. Mm-hmm. Mental health is a component of our overall health. It is the health that is concerning our thoughts and feelings and behavior. And we need to understand that our thoughts and feelings can get impaired. Yes? And when they do get impaired, subsequently, our behaviors also get impaired. Yeah. So we need to shift our conversation from talking about the severe spectrum of the mental health problems, the severe disease, the overt aggression you may see, or the suicide act, and start to talk about our feelings, our thoughts. How do they become impaired? What things can we expose ourselves to that change our thoughts, impair our thinking, and lead us to develop mental health problems? Mm-hmm. So that is the major challenge. People do not understand their feelings, their emotions, and even when they come down with a depression or anxiety, they do not know what's going on with them. Mm. Yes.
Okay. Sivu, what has your experience been working as a doctor in South Africa? Do you think that mental health has been equated to mental illness? Kind of like what we're saying, that perhaps people don't think of mental health as well-being as well, and just an understanding of our cognitive processes, our emotions.
Just to take it back a bit from a medical training point of view in South Africa, and I think maybe you guys might agree with me, mental health has always been on the back burner. I noticed throughout medical school, there was a way they used to refer to psychiatric services, psychology, things like public health, and it's called the fluffy subjects that people are forced to learn. It's not considered core clinical medicine. And for me, I think the biggest challenge is, even from training from a medical health perspective, from nurses to doctors to allied healthcare services, that we need to understand that training of mental health needs to be on the forefront. It can't continue to be considered as part of the fluffy subjects that we are forced upon to do by professors at the end of the day, And I think really a lot more needs to be done in terms of training of medical professionals to fully understand what it is, so that they can treat or help patients and identify it.
So you mean in terms of attracting people to the specialty, but also just generalists, so people within primary healthcare, GPs?
People within primary healthcare, GPs, the people that are able to the first point of call, because a psychiatrist is, I suppose, a specialist at the end of the line of treatment. But people need to present firstly to your general medical practitioners, your nurses, your primary healthcare services, before they get to the psychiatrists.
Yeah. And I mean, just in terms of population understanding as well, I mean, people might not seek treatment because there's stigma or there's misunderstanding of what is mental health, or because even that term, people just shy away from it. So, I mean, how do we kind of even bridge that gap, reaching the population to have a better mental health literacy, to be able to talk about feelings, to be able to talk about the fact that we all have mental health just like we all have physical health. What do you think, Father Valentine?
For the past 2 weeks, when I got the question, I said, I don't want to come to Oxford and sound controversial. And then I said, I should sound controversial. And I started looking at the question. It says, addressing mental health, Africa's invisible epidemic. And I started thinking, if I engage with this question as it's presented to me, we might run the risk of turning Africa into a continent of the mad. So I said, anyway, of course, I understand the spirit of the question. Maybe there should be a question mark at the end. Maybe we should say something else. Maybe we should start from a very positive approach where people will be able to buy into. If I tell my friends, come, I'm having a talk in Oxford. I'm about to talk about mental health, this epidemic in Africa, and there's this massive problem. Then we might move into the era of 1 in every 10, 4 in every 5. Let's go to Botswana and check if 1 in every 5 have got this condition. And then when you get to that community, where are the 1 in every 5? Let them come out. Let's find them. How many people here have got... so we go in with that mindset as if there is a big problem. I want to go and solve this problem. I need to go and engage with this problem. So I think that might be the problem, the way we present the whole question of mental health, whereby we present it from the beginning as if there is a crisis, there is a problem, we have to fix it, we have to solve it. And then some people will back out, some people will think, I can engage with this, and because it deals with, as I was talking about, thought, feelings and everything, I don't want to brand it as mad, and for things that I'm not sure about, I better back off. So the very presentation becomes a problem. So I think, so anyway, I'm happy with the question. But I was just, from the beginning, from the question, I wrestled with it for about 2 weeks, wondering, how do you answer a question that might lead you into a crisis, or with a kind of a presumption at the background that there is a crisis? How can I engage with the problem without negating the problem if I present it in that way?
It's a paradox, isn't it, that you don't want to just focus on the problem, you also want to focus on wellness and well-being and the fact that we all have mental health. But at the same time, there are people with diagnosable mental illness and people that do need treatment, that do need access to mental health care services that are not having access to that. So there's sort of this dichotomy, right? But yeah, what would you propose as the alternative then to what should we be asking, do you think? What question should we be asking?
I think the way she described it, mental health illness, that's the starting point, because there's always this confusion about when you talk about mental health, are you talking about the illness, are you talking about general well-being? So I think the first thing is about the emphasis should always, I think, is a narrative that will start, definitely I acknowledge the fact that whether you're moving from Egypt to Botswana, or from Ghana to Togo, or from, I'm trying to go around the continent, wherever you go to, you find people with bipolar, with eating disorder, just as you find in Vienna or on the streets of London, or just as you find somewhere in New York. But I think the first approach would always be, an African culture is a positive one. Every other culture is positive, but there's something unique about the African culture that is always positive in its approach. So I think that to resound that idea of that positive approach, that will be the first starting point. Then you'll be able to get people. Then you'll be able to engage with them in a conversation. Then they'll be receptive to what we're talking about. Okay, this person have depression. What are the hindrances? How can you engage with that? But the beginning, I think, or what I would suggest is that a positive approach should be the beginning. So once you talk about mental health, you start the positive approach, which would make people have the confidence to come out. So instead of going into a room and say, 1 in every 10 in this room might have, no. You say, we all engage in this way, and then from that point, you'll be able to get to, you'll make people more comfortable, more open to be able to speak about it.
Okay. Another sort of idea I have in my mind, and that perhaps is more relevant to South African context, but you can let me know if I'm wrong. So, I mean, and we had our former president, Jacob Zuma, who made a comment that, you know, Zulu people, we don't experience stress. Stress is a white man's disease. So, and I think often people studying psychology, for example, in places like Cape Town, it's often seen as sort of a thing that white middle-class people do as well, like studying psychology. Which is obviously problematic because you can't just have white, I mean, again, it's probably more a South African problem where there are more white people, but you can't just have white people as the healthcare workers within the mental health space, right? Because they're the manifestation of mental illness as well, and your experience of mental health will be culturally tied up, of course. So you want someone that's going to understand that to a greater extent. So how do you think in terms of this conception of mental illness being seen as a white man's disease? I mean, I don't know, is that common elsewhere in Africa? I mean, I don't know if it's just something that's said in South Africa, or is that experienced in Uganda?
Yes, well, Christine, that is part of the misperceptions that exist about mental health problems worldwide or in our continent. Because people have not been talked to about their feelings or thoughts, as if people do not know that actually these are the drivers of, you know, every action that they do. You know, the way you think affects the way you feel and ultimately the way you behave. These concepts have not been there in our culture, in our educational system, so people do not know. So when they hear about them, they think this is a concept coming from outside. But the reality is we all have a brain and we all have feelings and we all have thoughts. And there are things that we are being exposed to in our cultural contexts that impair our thinking, that impair our feelings, yes? For example, physical trauma and psychological trauma. This targets our mind. But we're not aware of these things as Africans. Yes? Things like poverty, the use of alcohol and drugs. People are not aware that these things are having an effect of their brains. When they get complications, they think they're being bewitched. They say, how come I drink with so-and-so and he's not getting a problem and I'm getting a problem? Yes? Chronic diseases on the continent, you know, like HIV/AIDS, you know, they do affect our brains and ultimately our thoughts and feelings, but people do not know this. Yes? So this lack of knowledge and the lack of awareness about these problems is what leads to these problems to progress and become severe until people are psychotic, they're attempting to take their own lives, and people see these overt behaviors. Of course, they're horrible. You know, an aggressive person destroying everything in the house, that's a horrible experience. So people are horrified, you know, by the manifestation of this. And then this continuous severe presentation of mental illness is what builds onto the stigma of the mental illness. You know, makes people not want to associate with someone like that. Makes people want to lock up such people, you know, having such a scary presentation. Yes? Yeah. But if we had knowledge, if we had prior knowledge, we can actually do something about it. We can diagnose, we can identify people in their early stages of the problem and make early interventions and prevent them from progressing to the severe end of the disease, which practically overwhelms everybody. Yes, everyone is overwhelmed, and, you know, people are so afraid, they just don't know what to do. You know, so they lock up these people in chains, they lock them up in their houses, they're having inadequate health care. They're being cared for in the most disrespectful way because people are overwhelmed with the presentation of severe mental disorder. So if we changed our conversation about mental health, if we cared to understand what it is, you know, no one wakes up one morning and they are violent. No one wakes up one morning and they go and try to take their own life. No, it is a process. They start with mild symptoms, which they often speak about, and they try to get help. But because people do not know what it is this person is talking about, they're not getting the help, but they're speaking out. So their problems progress until they get to that overt, scary presentation. Yeah.
So you've touched on a few things there. I mean, the one being sort of the awareness issue and sort of knowledge, mental health literacy in a sense, which I guess could lie at various, at various places, whether at education, sort of should we be learning about this at schools, for example, within the family context, through the media, where should this be happening? Also touching on the human rights violations that are prevalent. I mean, we had the life Epidemic crisis or tragedy in South Africa, where a lot of mental health patients were prematurely discharged from institutions to community facilities that weren't ready, and a lot of people ended up dying of starvation and neglect and things because the community organizations weren't ready to deal with that. So I think, one of the challenges is the human rights violations, the lack of awareness and education about mental health. But I think also mental health is a development and a human capital issue as well, right? Because there's all this potential that's lost, and because mental illness, for example, often strikes when someone's young, it's when someone's at their prime, they're supposed to be kind of, their career is starting out, or they've just finished school, or maybe still trying to finish school. So how do we think about it in terms of that as a human capital issue? Perhaps, Sibu, with your business background, I mean, have you thought about it in that light before, that all the years lost to disability due to people struggling with mental illness, that it's actually a human capital issue for Africa as a continent?
Yeah, look, I've never actually thought about it in that sense, but I mean, I do get what you're saying, and just to touch on what Dr. Ethel was saying, in terms of people don't know what they don't know. That's what I always tell people, like, you won't know the information that you don't know, therefore you can't diagnose someone as having a mental health issue if the family doesn't know about it, if they don't know about it, if they don't know what they're going through themselves. So it comes back to education. I'm a big believer in prevention, and I mean, even earlier on I was talking about the first step is how do you prevent this from happening? From a public health context, it's always better to prevent a condition before it happens instead of the curative that we always see in our countries.
Okay, so prevention. I know, Father Valentine, you also mentioned you think that focus on prevention is the way to go. So why do you think that? Just
building on what they've said, I think culture is very important. When you engage with the culture and when you intend to bring change, there are various ways in which you bring change into a community. And I think yesterday when the First Lady of Namibia was talking about how do you change, and she said one person can speak with a speaker or something, and they might still get change, and somebody might be doing their business behind the scene, and you might still get something done. I have an approach which tends to work for me sometimes. It's that if I intend to change that door, because I think the door is not really good, and when you work in a parish environment, I worked before in Canterbury, they're now in a prison, you have to be very sensitive to the needs of everybody. I might change the door, but when people return the next day, there'll be a new door there, but the door will still have the same color. It might still be brown. If it was brown before, I changed the color and it's still brown. And those now changed, and they can use that part. So I think one of the best approaches that I think with the context of Africa is that when you engage with the culture, because of our past, because of the history, because people are so sensitive to things of, is this another agenda? You made that reference between, oh, this might be a white man's problem, if you talk about stress. So why don't you bring it through the culture in a way that people would understand it as part of the culture and not something foreign? So that you're still doing the same thing, but the way you package the idea, the way you bring the idea, the way you engage with the community, you bring it in such a way that people will think it's coming from us. We are part of this discussion. We're part of this agenda. It's not something that I've come to teach you. I've come to impose it upon you. I've come to rescue you. I've come to save you. There's a problem here. But rather, you bring them into the debate. It might take a long process. It might be more, some people might think it's more expensive. But I think that might be my approach, that you effect change by using what is on the ground, bring people into the discussion, make them part of the discussion, then that slow change will be more sustainable.
Yeah. So, I mean, if we're thinking prevention, treatment, I mean, there always needs to be both. We can't also neglect the treatment of those with treatable mental disorders or mental illness. But obviously prevention, you don't know who is necessarily going to at least struggle with mental illness. So, I mean, how do you kind of balance that in terms of a budgetary perspective, in terms of prioritization within healthcare? I mean, if governments need to, yes, we focus on prevention, but we also can't neglect treatment.
I think, just to say something, I think treatment is also part of the prevention. Treatment is not out of the preventive process. It's actually part of it.
Yeah.
The concept of prevention is that you mentioned about human rights. We know that, take for example, post-traumatic stress disorder. Abuse of human rights would lead to, some abuses of human rights would lead to post-traumatic stress disorder. So whether you're in Congo or in Lagos or in Venezuela, if you experience a trauma, for some people, they might be disposed to that. So if you prevent this problem, abuse of human rights, you address issues of equality, you address issues of social issues, poverty, other deprivations, then you get to this part. Yes, you can prevent issues of making people aware, but sometimes people actually need to engage with treatment, various forms. Sometimes the treatment could be medication. But the idea of actually starting with medication as exclusive to the whole process of prevention is the part that I have a reservation to.
Yeah.
I was going to say, sorry, just going back to budgetary planning. I mean, for example, in a country like South Africa, right, I'm not quite sure what the budget might be, and in other places as well, but less than 5% of the health budget goes to mental health care services, which is a tiny fraction of something that needs to be treated, I mean, nationally. So there needs to be reform in terms of how health, government, and institutions look at budgeting for healthcare services. And as you mentioned as well, when they did at the Gauteng Department of Health, when they were deinstitutionalizing mental health care services, it was a botched operation, which was rushed because they were trying to save money, already money that they're not using, but they were trying to save money, and it ended up being an absolute failure. I mean, I'm not quite sure if everyone knows about it, but in one of the provinces in South Africa, they were implementing the institutionalization process of mental health care services, which is moving from institutionalized hospitals to home-based care to services within the community. But that was done in such a rush with no input from people that work within the mental health care services, or rather lack of input, to be correct, which ended up as a failed operation. Patients passed away starving, which the human rights issues come into. So there needs to be better planning in terms of giving money into mental health care services as a whole.
And I think also, what about creative approaches, right, where we have task sharing and task shifting, so it's not just thought of as the psychiatric nurse or the psychiatrist or the psychologist or the social worker that has to deal with this, but what about integrating it into our basic primary healthcare services? What about integrating it into HIV care, for example? And I know, Ethel, you've been very involved with that. Do you want to maybe speak a bit more to the group support psychotherapy that you've helped develop that was so innovative and has worked well in Uganda?
Yeah. So absolutely, you're right. We need to use existing health platforms that are already in existence, fully funded, to embed our mental health programs in those systems and get mental health care to the people who have done it. So in Uganda, what we have done, we have set out to target the most common mental health problem, which is depression, yes? And for which there exists a huge treatment gap. You know, if you look at the numbers that have the problem and the numbers who access treatment, the gap can be as high as 90%. And we know that depression impairs functioning. So it's going to impact human capital. I mean, if you have a whole community suffering from depression, their functioning is impaired, you know, at the workplace, be it the office or the garden, in their homes, in their communities. Yeah? So people are just sitting there resorting to taking alcohol and drugs, which make the problem worse. So what do? What have we done? So we have used the existing health workers, and we have gone in as experts from Makere and from the Ministry of Health to train the health workers in the healthcare centers, which are scattered in the rural areas. Okay, so we train them in basic knowledge and skills that can be used to overcome depression. And we're targeting mild to moderate depression because this is the commonest. And so once we take them through the program that we have designed, which basically teaches how to control your emotions, how to enhance your social support, coping skills, and also livelihood skills. Yes? Now, why livelihood skills? We went to this community before, as we're developing this program, and told them about it, and asked them what would make you come to this program? What would make the program more attractive to you? Is there anything we've left out that is of interest to you? And they told me, Doctor, you can see us. We are living in extreme poverty. We don't have money. So that in itself causes us to be depressed. So unless you do something about it, no one is going to come to your intervention. So this wasn't our idea, and we hadn't even thought about it. So we went back to the drawing board and actually read the literature and found a ton of research which has shown that poverty is a risk factor for depression. So the community was right. Yeah. Yes, they were right. So we said, what do? You know, we don't have money to give you. Yes? But then we read around livelihood skills, and we actually learned that communities can be taught basic livelihood skills. So we went back to them and said, you know what, you're very right. In this therapy program, we're going to include a component where we shall teach you basic livelihood skills, which you will use to be able to come up with an income-generating project within the means in your community. Yes, and start up something that can give you some money to meet your basic needs. Now, everyone was skeptical. They did not think this community, which has been used to being given staff, will agree to this. But we said this is going to be our stand. This is our guideline. This is our principle, because we don't have anything to give you. But we believe if we give you knowledge and skills, and we help you control your emotions, teach you coping skills, and you can cope with difficulties better, you will be able to come up with something to do as a community. So we went to this community and we were pleasantly surprised. Yes, we thought as soon as we mentioned we're not giving you anything, everyone would walk away. Yes, but once we explained our position, people stayed. People stayed along. Yes, and we were able to take them through this program, and by the time we got to the session where we're teaching the livelihood skills, the participants are actually, emotionally, they are already better, because of the skills we have taught them, and they are eagerly waiting to brainstorm on what activity it is that they can do. So in the end, it turned out to be a very successful program with 80% attendancy. Those that we recruited, 80% would complete the program. The participants go on to remain either in their groups or in smaller groups. They come up with an income-generating project which they continue in their lives. And we are following them up. And we're seeing that their depression symptoms continue to go down. They formed social connections with each other. They're even able to get further help, support, and funding from government institutions because they're organized in these groups. So this therapy program has not only helped these participants overcome their emotional problems, but has also led to positive social and economic outcomes. And the community loves it. And the local government people love it. And we've been able to move that from just one district to 3 whole districts. Yes? So we are hoping that this kind of model can be translated into other communities so that we assess the impact. Yeah? Because we have to do the experiments and see whether these things are working. And if they're working, then have the confidence to take them to the next community.
Thank you. I'm feeling so inspired. I don't know about everyone else because I think this is just exactly what we need. Using what we have locally. What do we have in terms of human resources? What does the community want out of this? Working with participants, working locally with the lay healthcare workers, and just coming up with innovative local approaches to things rather than just importing, as you say, an antidepressant or something. Not that, there's a role for the medication, of course, in the extreme cases. But as you say, what about the mild to moderate depression? What about people that are on their way because they're feeling hopeless about their situation? And I think also just touching that intersection between, how it's not just a silo of mental health. It's within the broader context of, the socioeconomic context. You can't just say, okay, well, I'll give you a pill to treat your depression, but, you still have the issue of you're unemployed and you don't have the skills to do something, you want to contribute. So I think that's great to have these kind of complex interventions that are addressing multiple issues that people are facing. And also how it's a community-based approach. I think it's like an Afrocentric approach rather than just the very individualistic approach that often we struggle with from that kind of the psychology that's imported from a Western context that people are often learning at university is very much focused on the individual and not on the community. And I think that's what I also love about your intervention, that it's this a group approach. And I just hope that we can be implementing that in more contexts or coming up with our own local approaches that use the group, that use the community. So it's wonderful. Thank you so much. Any other ideas about current solutions, current things that are working? So we've talked a lot about the problems, the challenges, and an innovative solution, which is so exciting. Any other solutions that people know of or kind of current things that people are trying that we can just give ideas for other contexts?
I have an idea, but I wanted to ask a question, if I may.
Yeah.
So it's now in Uganda. So you're doing it now in Uganda. Do you have plans to move it to other countries around Africa continent? So maybe to Nigeria, to South Africa, and to move it around. Is there any plans for that?
Yeah. So this morning we heard our keynote speakers encouraging collaborations between fellow African countries. I think that's the only way that this intervention can move from one African community to another. If there are any experts here in mental health that would like to try out this intervention in another community, we can collaborate together. because we have, the design, the protocol on how to go about the event. We have the expertise to analyze the data, so it's not difficult. If we're willing to collaborate, we can move this to another community.
I was going to say, just to add on that though, for example, South Africa has a mental health policy framework, right? Instituting very similar strategies in terms of what Dr. Ethel was talking about. However, the implementation in itself was not executed as well as what she was explaining, because community-based healthcare services, mental health care services are there. They've piloted it out in certain provinces. However, the implementation of it ends up that the people aren't accessing what's in the policy as opposed to what we need to be doing.
So again, you can have good policy without the implementation. It's not very useful, but it's a good starting point to at least have the policy in place. Whether to protect against human rights abuses, as are so common, or just to kind of say, well, the services need to be there. So the policy framework, I mean, it's going to be the starting point, I guess. So the task shifting approaches. I'm just thinking if there's, in terms of the social services, do you think they should be involved more? What about religious institutions or other kind of NGOs? Do you think they have a role to play?
Yeah, I think empowering people, as you said, you empower them, emotional resilience, so that they'll continue to grow in that sense. But of course, working together. Faith, of course, we're talking about Africa. In the world, I believe faith has a role to play when thinking about addressing people's mental health, a very crucial part to play. Faith can be supportive, and it could also be destructive if it's misused. So instead of somebody assessing a psychiatrist, they will say they want to meet a priest for some spiritual healing. I don't do spiritual healing, but I have to go and meet a psychiatrist first. Now, but of course, we could work in partnership. And when you bring all the various areas together, then you'll be able to help the person in a very holistic framework. So faith becomes supportive, not part of the problem. But to completely reject one part and focus on one part would create that problem. But I really like the approach that she mentioned. And I was just thinking in my head how you implement that in my context, in a prison context. And the whole idea of whereby you meet people where they are, you see their talent, and you empower them with their talent. You're not judgmental. You're not thinking about, I want to help you think, but rather you get to where they are and you support them and you enhance them. One part that I think is, how do you, it's a solution but also a question, how do you get people who might be diagnosed with mental health illness, doctors, you've diagnosed them, how can you now get them to be part of this program that they will move from receiving the services to actually they'll be part of the people who are actually delivering the services, if there's any avenue for that, whereby you don't just, you're not just supporting them, but you actually get their talent so that they also play a role in the process of their healing. They play a role.
I've seen that approach used within HIV positive mothers. There's a mentor mothers program, for example, where the mother themselves will become a mentor for other mothers, and they're kind of supporting each other. So it's quite a useful model in that who's more of an expert on the disease than someone who's experienced it themselves, right? So I'm sure that's an approach that could be used, especially when someone is in the recovery phase from depression, or they'd probably be in a place to be able to now help others who are in that situation. So we are running short of time. We have about 10 minutes left. So what I'd like to do is rather open it up to the floor now for questions, because I'm sure people have many, and there's so much to touch on, and we have a wonderful panel to answer the questions. So, okay, we've got, I think the hand at the back was up first, so let's start there, and then we'll come back down to the front.
Thank you very much, panel. I was moved by some of the contributions this afternoon from you all. I've got a question sort of aimed at my good friend Father Valentine there in the middle, and it's to do with his experience in the prison that he works in. What percentage of the inmates, let's call them, at his prison are Afro-Caribbean? Because I'm Afro-Caribbean. I've used this third time today, and it's to say that I'm not African per se, but a watered-down version from a small island called Montserrat. And to comment on the fact that from that community, I know that a lot of Afro-Caribbean people are not only in prison, but they're also in mental health institutions in this country. And I always thought the reason for that was because my people are like fish out of water in England, and things like the cold weather, lack of sunlight, lead to depression, and therefore lead to mental illness. So that's why I'm rather interested in the idea that in a continent where there's lots of sunlight and lots of sunshine and warmth, you might have an epidemic also, and things like depression exist. So that's my kind of question to you, and also my commentary on this topic for today.
Oh.
Any comments back? Response? Okay, yeah, we can take two first. Okay, thank you. Do you still have yours? Okay. Yeah, so we'll take two and then answer them, and then we'll take another two.
Thank you. My name is Mandine Lovu, and I'm doing my Master of Science. Master of Science at SOAS. And my research focuses on instances on intergenerational trauma and state denialism and how that feeds into issues for good governance. So as a Zimbabwean, I speak as a Zimbabwean right now, I have a question either for Dr. Sibu Madikana or Dr. Ethel. What insights or solutions can you prescribe for a country that's dealing with a legacy of trauma, a legacy of violence and denialism within a state that denies that? And again, how do we help people overcome the stigma of wanting to learn how to figure out what the symptoms are and to address them at the early stages? I know in my country there's an initiative called the Friendship Bench, but not everyone will sit on that bench because it's stigmatized. You won't have people at high levels of government or executives or, sitting at that. And it's a countrywide problem, depression and mental illness. So how do we begin that conversation in an apathetic country? Thank you.
Okay. Would you like to address the first one?
I'll wait for them to go first.
Okay, so we'll do the second question first while you think.
Maybe you can take the first, I'll take the second part of that question.
Okay. Thank you very much. It's a difficult question, but it is a very, very good question. I come from a country, Uganda, where at one time our president addressed the nation and said that he doesn't see the use of, that some disciplines are useless, like psychology, and, government has no time for that. So, like I said, instead of reacting to that, we responded. I recall many psychologists wrote in the newspapers responding to the president, actually showing, kind of like educating him that psychologists and psychiatrists are important because People go through traumatic experiences, be they physical or psychological. The country had been enduring a civil war in the north for over 20 years. So it was more of bringing the evidence out, yes, about what trauma does to the mind and educating the president, yes, about the reality of this situation and that we actually need to do something about it. So another way to, so what we actually need to do as the experts to overcome this stigma is to also provide the solutions. Yes, we have to come up with culturally appropriate solutions and then offer them to our governments. Yeah, we should not sit back and say, oh, well, I'm an expert trained in Oxford, Johns Hopkins, they should come looking for me. No, we should make ourselves relevant to our governments. We should go with to them, provide them with the information that they need about these conditions and actually tell them how you can help. This is how we have approached the issue of depression in northern Uganda. We've actually gone to the heads of all the local governments in the 3 districts where we're operating, and stated our case and told them what it is exactly that we are going to do, yes, and ask for their permission, to go into these communities. And as we work, we're giving them feedback. We're bringing them testimonies from people in the villages that have experienced these programs. And this starts to shift their thinking, about mental health problems. They see their people being helped and they're getting interested, and the positive thing has been they're urging their health workers to participate in our training and, so that these programs can continue. So as the experts, as the health workers, we have to get in there with our governments instead of criticizing them or reacting to these statements they're saying out of ignorance. We need to be there with them and gently, use the art of gentle persuasion to show them that actually this is important. And guess what? We have a solution, that we're rolling out. And these are the results. It is working. And also government can then start to respond to you and kind of want to collaborate with you. In my experience, the persons participating in our group interventions, once the therapy is over, they stick to their groups, they're organized in their groups, they go and register their groups at the sub-county, and the government is saying, wow, these people are really, this program is organizing people. Yeah, and so they're giving our participants first priority to get government resources, and women who we found having nothing, depressed, we came in, treated their depression, and they're now able to access resources from the government and doing bigger projects, sending their children to school, and really their lives being transformed. So really the point is us to work with our government, to get in there with them. And our role is continuously to inform them, to educate them, but not to react and brush them off and criticize, The First Lady of Namibia said that criticism does not work with politicians. Yes, so we have to find other ways to put our information across. We have to be in this together, and eventually we'll make an impact.
Yeah, just quickly touch on, and this is like from a community perspective, how do you destigmatize, this is across all kind of illnesses, HIV, mental health illnesses. You need behavioral change. How do you get behavioral change? You need education. We need a cultural shift, and I think civil society has a lot to play in this. NGOs, people from within the community, we need that cultural shift to understand that mental illness doesn't come from witchcraft, doesn't come from the kind of old thinking that people had, but we need to educate communities in order to get them to understand, because again, they won't know what they won't know, and they will fear what they don't know.
Okay, so we basically have run out of time, unfortunately. I don't know if you can perhaps continue the discussion about the Afro-Caribbean population in the country outside afterwards. But just to say thank you so much to our panelists. I thought it was a very interesting discussion, and I think let's continue the conversation. And the next steps, I think we have got some action points we can take going forward, including about raising mental health literacy and awareness, and also to do with innovative local approaches and sort of models for doing so. So thank you very much, and enjoy the rest of the afternoon. Thanks to our panelists.